In this video, I'm going to address the top 5 questions I get for patients who are coming to me for a clitoris reduction. Hello, my name is Dr. Saif Gallagher. I'm a plastic and reconstructive surgeon based here in Miami, Florida. And this is definitely a growing procedure in my practice. Not many of us surgeons do this procedure, Laboplasty, clitoral hood reduction. Yeah, most plastic surgeons do that now. But clitoral reduction itself is an unusual and very specialized procedure, but there's definitely a growing demand. So in this video, we're going to jump into the top 5 questions I get from our patients. So the number 1 question I get is about sensation after surgery. This surgery takes me 3 hours to do. We're working on a tiny area and I do it under magnification. And the whole aim of the game is to do it nerve preserving. So we're not getting rid of any of the nerves down there. We're getting rid of the erectile tissue, which makes the clitoris too big, makes it stick out, but we're really carefully preserving all those nerves. And what I've noticed from patients is that sure, initially, there'll be swelling, bruising, they won't be in the mood, but as they recover from the surgery, sexual function tends to be very good. And actually, most patients report that it's better because they're less self-conscious after surgery and they feel better about their bodies and having sex and therefore get more pleasure. There may be a little bit of an adjustment period, a little bit of time, because obviously the clitoris isn't going to be as easy to find as it was before, but this is a nerve-sparing procedure and outcomes from this point of view are excellent. The second most common question I get is, will it come back? A lot of patients who undergo this procedure are really upset by how the anatomy looks down there, and especially when they get aroused, a lot of girls will describe it as if it feels like they have a penis, that it sticks out too much, and a really common concern is it going to come back? And I will tell you, in all my years of doing this, I've never seen it recur, meaning that once we get rid of that erectile tissue, the patient won't be able to have those symptoms. Things will be the normal anatomical size, and that is something they don't have to worry about. The third most common question is, what caused this? Why am I like this? And in a lot of cases, it's what we call idiopathic, or it's just your anatomy. It's like having, let's say, big feet or anything else. It's just a normal variation in anatomy. But if you're not happy with it, obviously it's well within your rights to change that, and we have a procedure for it. So I always emphasize to girls, it's not necessarily a pathology in most cases. In some cases, however, it can be associated with something wrong, and the most common thing that's wrong is taking medications. So for example, if a patient has been taking anabolic steroids for bodybuilding, it's very common for girls to take testosterone these days, and if they've had a lot of testosterone in their bloodstream, that can cause it. Polycystic ovarian syndrome as well is also notorious for causing this too. There are various other more rare cases where it is part of something else that's going on, but in the vast majority of patients that I see, it's for one of these reasons. The fourth most common question I get is, well, what's involved with surgery? What happens? So most of my patients fly in for this surgery. Usually I recommend they're here in Miami with us for at least 5 days. And surgery itself is outpatient. It takes me usually about 3 hours to do. And you're able to go home typically within an hour or two after surgery. Thankfully, it's not a very painful procedure. We do a maneuver during the surgery to block the nerves down there. And for most patients, this works really well. Typically, most patients will return to office jobs, for example, in 1 to 2 weeks after surgery, and then working out at least 2 weeks before returning back to gentle workouts, but typically 4 weeks before more strenuous activities, and at least 4 weeks before sex. And the fifth most common question I get is, do I need a labiaplasty as well? And that really depends. So typically while I'm in there, because we have to readjust the anatomy to fit everything to the new size of the clitoris and lift everything, so most times I'm doing somewhat of a labiaplasty. But as I mentioned earlier, most of my patients who are coming to me for this procedure have had 1 or more labiaplasties done before. So usually there's not much otherwise to take away. We'll discuss each patient individually if there's some asymmetry they don't like, or they don't like like the size of the labia, we can of course address that at the same time as the surgery. But I'd say about a third of my patients do a formal labiaplasty in addition to what I'm doing with the clitoral reduction. But again, that's because most of them have had one or more labiaplasties already.